All right, the next section deals with hypertension, and hypertension basically is an increase in blood pressure. Now, it's important to recall that when we have hypertension, that can involve either the pulmonary circuit or the systemic circuit, so we have two independent circuits in the body, and either one can develop high blood pressure. We will talk about pulmonary hypertension, however, we'll do that in Chapter 9. So at this particular point, we're focused on the systemic circuit, and we're talking about systemic hypertension or systemic high blood pressure. Now, systemic hypertension is defined as blood pressure greater than 140/90. This definition changes on occasion, but it's a pretty good baseline number to be familiar with. When we think about this definition of hypertension, with this number we can define about 25% of the U.S. population as hypertensive. Recall that the normal blood pressure is less than 120/80, and so if anyone's greater than 140/90, we would then classify them as hypertension. Usually when patients have hypertension, both the systolic and the diastolic pressures are increased. You can have isolated increases in systolic or diastolic pressure, and that would also qualify as hypertension. Remember that when we have systemic hypertension, we can divide it based on the etiology into primary and secondary hypertension. In primary hypertension, we don't know the etiology. It basically represents about 95% of cases. And because we don't understand the etiology, the only thing we can really talk about are the risk factors. And so there are some specific risk factors that are related to primary hypertension. For example, age is an important risk factor. We know that as patients age or as people age, hypertension becomes much more prevalent within the society. Race is also an important risk factor. There's a much higher risk in African Americans, and there's a relatively lower risk in Asians. Obesity obviously is a risk factor. We're all well aware of that. Stress is thought to be a risk factor, lack of physical activity, and a high salt diet. Now when you think about high salt, remember that your systemic blood pressure is a function of your stroke volume, and the diastolic blood pressure is actually a function of the total peripheral resistance. And sodium, interestingly, actually increases both the blood volume and the total peripheral resistance. And so sodium has an effect on both the systolic and the diastolic blood pressures. Secondary hypertension, on the other hand, is due to an identifiable cause. It only makes up for about 5% of cases of hypertension. One classic cause among many is renal artery stenosis. And the idea here is that if this is the aorta and this is the renal artery, if you have stenosis of the renal artery so that there's less blood flow going through the renal artery, then that low blood flow would decrease blood flow to the glomerulus. Recall that the juxtaglomerular apparatus of the glomerulus will respond by secreting renin, and renin converts angiotensinogen to angiotensin 1. Of course, angiotensin 1 then goes to the vasculature of the lung and gets converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 does two things to raise the blood pressure, so it's kind of conveniently named. Again, angiotensin 2 does two things to raise the blood pressure. Number one, it directly contracts arteriole or smooth muscle, so that increases the peripheral resistance. And so that's the first way by which it raises blood pressure. And the second thing that angiotensin 2 does is that it promotes adrenal release of aldosterone. Of course, aldosterone then goes to the distal convoluted tubule, and it increases resorption of sodium. Basically, it grabs sodium and dumps potassium. And when it grabs sodium, eventually water will follow, expanding the plasma volume. So angiotensin 2 raises the blood pressure by directly contracting arteriolar smooth muscle and by promoting release of aldosterone from the adrenal, which will then grab sodium from the distal convoluted tubule and eventually expand the plasma volume. So this is a very important physiologic relationship to be aware of. It's very high yield for examinations. Now, of course, if you've got renal artery stenosis, then you're activating the juxtaglomerular apparatus, so you're going to be releasing a ton of renin. And so in patients with secondary hypertension, you often see an increase in the plasma renin. And if you look at both kidneys, usually the stenosis is going to involve one kidney, and when it involves one kidney, there's going to be a decrease in blood flow across that kidney, and so this particular kidney will become smaller, and so you'll have unilateral atrophy of the affected kidney in renal artery stenosis. What can cause renal artery stenosis? There's two very high-yield causes to be familiar with. The first would be atherosclerosis, and this is what we would classically see in an elderly male. So atherosclerosis can cause stenosis of the renal artery and decrease the blood supply that's going to the kidney. The other way by which we can get renal artery stenosis, at least classically, is something called fibromuscular dysplasia. This is a developmental defect of the blood vessel wall. It results in irregular thickening of large and medium-sized arteries, especially the renal artery, and it's classically seen in young females. So renal artery stenosis in an elderly male, you think about atherosclerosis, and renal artery stenosis in a young female, you think about fibromuscular dysplasia. Now we can separately classify hypertension as benign or malignant as well. So this would be another way to look at hypertension. In benign hypertension, we have a mild or moderate elevation in blood pressure, and most cases of hypertension are actually benign. This is clinically silent, and it damages vessels and organs over time, and we'll discuss some of that damage as we move forward in this particular chapter. Malignant hypertension, on the other hand, is a severe increase in blood pressure, characteristically greater than 200 over 120, and this can arise in one of two ways. It can either arise in a patient who has pre-existing benign hypertension. For example, the patient's got some long-standing hypertension and all of a sudden develops malignant hypertension. But it can also arise de novo in that the patient doesn't even have to have a history of hypertension. They can simply present with malignant hypertension. Patients with malignant hypertension are going to present with acute end organ damage, classically with acute renal failure, headache, and papilledema, and of course this is a medical emergency. Now remember that patients who have severe hypertension, they can develop fibrinoid necrosis of the blood vessel wall, and we talked about that in Chapter 1. So that concludes our discussion on hypertension.